Market trends in mental health care is our episode topic. Rejoining us as guest is Bryan Cote, a managing director in VRG's Healthcare Transactions and Strategy Group. So let's get started.
Welcome to the VRG Nurse Executive Podcast. VRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. VRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the VRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about VRG, please visit thinkvrg.com. Now here's your host, Nick Chmielewski.
Bryan, welcome back. Thank you so much for joining us again.
Thank you, Nick. Great to be here.
Our topic today is about substance use disorder, behavioral health care, addiction. Going to group all those together. What's going on in the market right now with respect to these different health conditions and disorders?
There's been a lot of change since, I'd say, the last decade, given mental health parity, which has helped at least raise awareness for the condition. Stigma, though, still very much exists, even though I think a lot of the population, particularly younger people, are more open to talking about their mental health, access to care for a lot of the population, which means like a therapist or psychiatrist has improved a lot. But the effect of social media and coming of age in the 2020s for teenagers and young adults is a real issue. And so the need for mental health services for anxiety, depression, PTSD, substance use, sports betting is massive. And there's just not enough subspecialists to handle all that. I say subspecialists because dealing with compulsion for betting is very different than dealing with addiction to alcohol. It's very different than someone who had a trauma as a kid, is different than someone who's dealing with friend relationship issues in high school or middle school. And yet all of those sort of come together. And I think that the market, the healthcare market, the business market has done a really good job trying to say we can collect therapy professionals, psychiatrists, psychologists, LCSWs, nurses trained in mental health, and provide services virtually or in an office setting to help with your needs, whether you're an adolescent or 20-something or an older individual. And the reimbursement environment for that, commercial and government pay, is really good. There have been increases really across the board with all those payers. The less oversight of authorizations initially. It used to be like a big thing. We're not going to cover your care. We're going to tamp it down. That's gone away. I think what is happening now, though, is this emergence of innovation outpacing policy. For example, we have a lot of new companies that are serving the middle road of mental health, like intensive outpatient care in a center for someone who's maybe needs inpatient care, but we can do this in an outpatient way at less cost. A weekly visit isn't enough. And there's a lot of regulation right now around those centers. There's some confusion about like how many hours they provide to patients, what they should be paid, how they should bill, what the credentials and the quality of care is. And I think all of that probably will improve over time, but there's some disconnects right now in terms of like where these new operators sit. Because all we used to think about, like when I grew up, was it's like inpatient psych services for people with like severe mental health issues. And then you might have a psychiatrist. Problem now is like the psychiatrists, for the most part, half of them in the country only take cash. They don't take insurance. Psychologists can charge $300-$400 a visit, cash only. They're not taking insurance because they're filled. Their days are filled. Half the market is taking insurance. And so that's a positive, but you still have this, there's so much demand. I don't need to accept insurance. And so you have a have and have not situation. We've come a long way. I think what a lot of the investors in mental health are leaning toward is like outpatient care or continuum of care, providing like a residential visit for people, outpatient visit, and telehealth. I would encourage anyone, whether it's a health system or a payer, to really lean heavily into specialized mental health treatment. Number one. meaning don't just provide like everything. Try to be a dedicated service with really well-trained clinicians, whether they're nurses or therapists or physicians of a specific kind of episode or issue. Like there's even a business that does suicide care to figure out that there's real risk here. And we're going to spend 3 months wherever the patient is providing services to them. So we prevent that and get them to a good place. That's a really good model that I think the healthcare payers in this country are like, wait a minute, I'm not used to that. I know how to pay a psychologist or a psychiatrist for a visit. Again, that's like a good example of the innovation outpacing the policy that needs to catch up. The second thing, and I think this is probably relevant to hospitals, case managers in hospitals, discharge planners, anyone running a health system, the recovery models in this country, the nonprofits, your local community-based services that do a lot to help people with addiction and or stay well. Sometimes it's both of those things and deal with things they never resolve, like self-confidence and anxiety, depression. They're underutilized and underinvested in. And there should be, or there ought to be a much bigger investment in these nonprofits. Now, whether that means a health system partners with a nonprofit that's focused on recovery from addiction, in a discharge, you get them to that entity to manage their care, or it's a inpatient facility that partners with a nonprofit locally to make sure that their recovery goes well. All of that is pretty important. I know a lot of these entities that are focused on running community, sobriety, they do support AA. They're very much about just like getting everybody moving in the same direction, which is what a lot of people who are going through addiction or mental health struggles need. And in a lot of the country, I've done some work, done a documentary with my son around this. These clubs are forming and they are a real solution to prevent relapse, keep people from needing hospitalization. And they're really good about just improving the overall mental health of individuals who either have gone through addiction or showing signs of it. The problem is there's no healthcare investment in it. We often deal with the private equity community, lenders, bankers whose investment has been more geared toward like center-based care, inpatient care, maybe some of this intensive outpatient, because the economics are there, right? It's $1,000 a day or $700 a day, 30 days. That's a good model. That's good margin. I think if their investment started to move toward at least more collaborative care and these like community-based nonprofits, I do think the health insurance community will support that and pay for that. But we're not quite there yet.
It seems almost, you talked about the disparity there between the haves and the have-nots, but it also seems like there is a conflict here that exists between the nonprofits of how do I keep these patients in the community? How do I provide the best possible care at the lowest cost versus the for-profit environment, which is frankly, where do I get the greatest profit, which is in an inpatient setting, which may be somewhat counterintuitive to the patient's best needs.
Yeah.
Tell me your thoughts about that.
The nonprofits I've talked to have said, and I say nonprofits, it could be mental health centers, community-based mental health centers. It could be some of these, I mentioned the running clubs. They're like, wow, there's all this investment in mental health care and addiction-based healthcare. It's not going to us. And we're doing all the work and we're dealing with individuals when they come out of the facilities and are already needing to go back in. We're dealing with law enforcement. We're dealing with getting them back into work. And we don't have the funds at all to maintain the staff, train the staff, provide the services. Because really what most people need is like a liaison, a mentor to help them through recovery. There are some really good examples of companies in the last 5 years pre-COVID who said the best way to get at mental health crisis and addiction treatment is a real like peer-to-peer model, outpatient driven, meet the patient where they're at, remove like this idea of fee for service and everything's about a billable episode. And they've gone to big insurers and said, we will lower your total cost of care. Pay us for that. Pay us our fee. We'll take risk on everything. You just have to let us do our work. And it has like the seeds and the elements of a true nonprofit, grassroots, boots on the ground kind of model. You're right that there's a disconnect. I think the for-profit entities need to just at least plug these nonprofits in because they're starting to be forced. Like if you're a residential treatment program, you're starting to be forced contractually to prevent or limit a relapse or readmission inside of 3 months. Like hospitals, obviously, they are on the hook. I think nursing homes as well for readmissions. Like this goes back to 2008, nine,
Yeah.
30-day readmits, I think it is. Now we're starting to see mental health care facilities, inpatient and residential, be on the hook for 90-day or 6-month readmissions. And the readmission rate or relapse rate for eating disorders, addiction to alcohol and drugs, and sometimes mental health conditions is wicked. We're talking, I just gave away my Boston roots, 50, 60%. And it's like, why not have a nonprofit running club wellness model in your plan of care? And even if it's not driving margin, you're going to be on the hook for that. So nobody's really waking up to it. I wish they would.
And what does that look like? What is that like? Okay, someone's listening today, they're a CNO, they're over a health system, and they've got a couple inpatient psych units, or maybe they have a behavioral health care facility in their health system that they oversee. And they're like, all right, I need to work on my readmission rate. And maybe the club wellness model is going to be my one piece of my puzzle that I should look at implementing. What exactly is that? What does that entail?
If you're head of the discharge case management for those coming into your hospital, say in the Boston market, whether you're with Partners or whether you're with Mass General or any of the hospitals up there, and you have someone who's either in there because they have an opioid problem, or they've been in and out, or they've been in your psych unit, I think one of the and/or detox, like maybe that's within your system. One of the discussions is some education about, there's a club up there called the Boston Bulldogs Running Club nonprofit. And there's clubs like them in different markets. And I would say, here's the contact, here's the appointment card, here are the 3 locations you can go and the time you can go. And then maybe even have someone from something like rounding, right? Have someone from the club maybe come in and meet them and have it be the next day. Now you need to have accountability. They need to show up. Problem
Yeah.
is that person needs to show up. If they do, these clubs are designed much like acute care facilities to surround them with support and make sure they don't fall off. It is incumbent upon the individual, particularly with addiction, to show up. That's the goal. You can't force them to. But I do think if I'm a CNO or if I'm a head of a psych unit of these facilities, in discharge, I start to identify some of these organizations in my market. And I suspect that does exist today. The problem is probably there's not a lot of economic incentive to do it, which if that starts to change and we start to see government insurers, Medicaid insurers, states, and the commercial insurance market start to say, look, we're going to make sure you're at least paid for that transition and that recommendation, or we're paying these recovery centers for these recovery nonprofits for their care. Maybe there's some additional payment that hospital systems can get for making those kind of referrals. Maybe that can be part of their value-based score. I think there's probably a lot that insurance and state policymakers could do to improve those transitions to those entities.
And then on the employer side of it, because the chief nursing officer also is employing a lot of nurses and those that report up to the nursing executive. What types of services should be offered potentially as you work with your HR colleagues in looking at benefit plan packages to really ensure that you're taking care of your employees with respect to substance use disorder and other disorders such as eating disorders and things of that nature?
There's been a lot of development there. I think there's a lot of investment in telehealth companies large employers, whether they're healthcare companies or hospital systems or just manufacturing company, in telehealth businesses that are available at any point during the day and sometimes they have substance use specialists and they're basically paid to do a 20-minute, 40-minute, 60-minute visit anywhere. So it could be at the office of the individual, so they don't have to run out and go see the psychologist. Similar to like physical therapy, we've even seen companies that do that. They can provide like a PT consult while you're at work. It's the same concept, and the employer basically pays the per employee per month amount of money to make sure it's a baked-in benefit. And it's $2 that they might pay for that, and it's rolled up. The problem is it usually is only covering 6 to 10 visits, 6 to 8 visits usually. And so for someone with substance use, that's not enough. So you have to have some sort of community partner support to really make these things work. Or if I'm an employer, I round it out. You get to that 6th visit and you need more. You need to have some partners that provide the longer care.
Can you talk a little bit more about your documentary film that you're working on? or finalizing, I should say.
Oh, yeah, it's final. I'm trying to get this out into the market. It's more a labor of love. We were talking at the beginning, Nick, my son's at finishing college and school and is a sports talk podcaster. That's his big dream and has a lot of like video experience. So I said, look, let's tell the story of this nonprofit. I mentioned them a bit ago from Boston. That's a running club. And well, let's feature these runners in the club and their stories, which we did. They're all interconnected in their path towards sobriety. They open up in ways like we've all seen stories about people opening up about their healthcare issues or their addictions. What we wanted to show though is where they are today, which is like an amazing place, 5, 7, 8 years since their last drink. But they talk about like all the addictions they had, and the running club, as well as the wellness support they get, has been instrumental into saving them. So we went around and we filmed them and tried to pull a story together in a documentary. And personally, I write columns all the time. That's in research reports. I was like, all right, I can dip my toe into making a film. I had no idea how to do it. I hope it educates anyone who's gone through addiction can see it as a really positive story that you can do this or families struggling with it now. That's my hope. And for those in the healthcare community, because like that's where I spend a lot of my time, like you, I hope it resonates that models focused on recovery, I mentioned nonprofits, start to get attention in different ways. If we just pivot a little bit of our policy in this country toward a little bit of our funding toward that, I think it'll go a long way. So that's what we wanted to highlight. It should be out next year.
And what's the title of it?
The Boston Bulldogs. Nothing
The Boston
very creative.
Bulldogs. All right.
Boston
And coming out in
Bulldogs.
2025.
Early 2025. Yeah.
We are recording this episode in late 2024 for our listeners, just for their edification. You've mentioned the running club a couple of times, and I hate to ask this question, but I hate running. So thinking about people that work with substance use disorders, I do enjoy other activities. How do these nonprofits figure out, one, what that activity is, and ensuring that the community is going to have enough people, or people that may not have that particular interest but still has access and an ability to be able to be in that club format?
I think the community is the key to the whole thing. You
Okay.
show up, you're supported, you're greeted by everybody every time, particularly if no one knows you. In the running thing, most of them were not runners. Most of them are not. Many showed up with weight issues, self-esteem issues, still
Interesting.
smoking.
Okay. Wow.
That said, and it's all about like wellness community. And why not a volleyball club, or why not something with activity?
Yeah.
Pickleball is a phenomenon in this country. I could see that forming as pickleball is an example of something that's helping people stay active and have socialization, particularly as they get like into their even senior years. There is no problem. There's probably sky's the limit on what you could do with this. It doesn't have to be running. Obviously increases serotonin. It has a lot of positivity, helps you feel good.
Yeah.
Even if it takes you a heck of a long time to get around that 1.5 miles. I think it's probably all about, it took me 20 minutes this time, 18 minutes the next. By 6 months, oh my God, I ran a mile without having to stop. Then I could do a 5. It's the goal setting and having goals and working with someone. I think that is and if we improve that, we probably can address a lot of the mental health and physical health issues in this country.
But yeah, you're also getting
Obviously-
people out and getting them moving. So I was just also, my mind started going to, well, what about seasonal type sports? Like I love skiing, right? But
100%.
that may not work if you're in Florida or something to that expect. But
Sure.
where do you find the right activity? And I think to your point, it's what the community is willing to accept.
Mhm. Exactly.
Any closing thoughts as we wrap up this episode?
No, it's been great talking about this. So I appreciate your time and your questions. Thanks, Nick.
All right. Discussing substance use disorders and other mental health parodies as it relates to the market and the industry and the payers has been our episode topic. Bryan Cote, BRG's Managing Director with the Healthcare Transactions and Strategy Group. Thank you so much for your time. Appreciate it.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group,
or their other respective employees and affiliates.